So someone wanted to know about surgical decompression for traumatic optic neuropathy. And as the name implies, it's a neuropathy of the optic nerve secondary to trauma. And because the orbit is shaped like an ice cream cone on its side, even if the force blow is here, the force wave is transmitted to the optic canal. And so the traumatic optic neuropathy is thought to be an indirect traumatic force channeled by the shape of the orbit right down into the optic canal. And because the optic canal is a small space, you can cause like a compartment syndrome here. And that's the rationale for giving steroids to patients with traumatic optic neuropathy, which is a completely different conversation. However, because this is the presumed mechanism, if we see a fracture in the canal with a bony fragment that's producing the optic neuropathy, that is one indication for surgery. Take out that if you have optic canal fracture or bone fragment poking on there. Or if you have a hematoma in the sheath that's acting as a compressive lesion, you could do a sheath fenestration and drain that blood out. It's much, much more controversial, however, for surgical treatment of traumatic optic neuropathy if you don't have an optic canal fracture or a bony fragment or a sheath hematoma, which are much more clear indications for surgery. So just decompressing the canal, either with neurosurgery, orbit, or combined approach, is a big procedure. And so we really don't have evidence-based recommendation on surgical treatment of traumatic optic neuropathy. But if you're going to do it, probably earlier is better, because the presumed mechanism is edema and a compartment syndrome in the optic canal. And so if you're going to do it quicker. Whether that it means 24 hours or 48 hours or 72 hours, we don't have any data. I prefer to limit my surgical indications to these: fracture, canal fragment, sheath hematoma, or if we have definitive evidence of a decompressible compressive optic neuropathy that either is steroid responsive and steroid dependent, or ironically, steroid non-responsive, you could offer surgery in this setting. But it's a could do. It's certainly not a must do because there's no evidence base. It's not a should do even, which is a standard of care. It's a practice option called a could do. And because we don't have any data, it might be voodoo and not just could do, and certainly not should do or must do.